Everyone, and I want to welcome everyone to this webinar hosted by the SSLN Learning Network. The title of this webinar is Understanding HIV Epidemic Trends. We will be looking at HIV incidence data, trends, and insights, and what this means for prevention, programming, and prioritization. My name is Dr. James Aneni. I'm a medical doctor as a way of background, but I'm currently the Director of Community Prevention and Care Services at the National Agency for the Control of AIDS, NACA, in Nigeria. I have experiences in research, monitoring and evaluation, policy, and planning. And I'm very honored to be chairing this session. Welcome once again. Like I said earlier, this webinar will give us opportunity to explore HIV incident data trends and insights, and what this means for prevention programming and country priority prevention programs. This becomes even more important as we approach epidemic control in so many countries across the world. And as countries begin to take control of their, begin to own their epidemic, their response. First of all, I want to let me draw attention of our online participants. If I can have that slide, please. That speaks to our mentee program. Okay, so for our online participants, I'd like to run a few information by you. Participants can join, can choose two options to answer online. The first option is to join at mentee.com using the code that is displayed online, 89000784. The second option is to scan the QR code on the screen, if you can see that. Okay. I would like for you to take a look at the question that is displayed online to your right, which states, which goes, what is the one word that comes to mind when you think of the importance of data for impact? So log in and sign on, and then we'll revert back to you as you respond. Please, if I can go back to the agenda, please. So again, good afternoon. So we are going to be starting this session. I've earlier introduced myself and given a few opening remarks regarding the importance of HIV incidence data in our prevention, programming, and prioritization. We will be taking, we'll be hearing from a few speakers. I've gone through the background of the speakers we've listed. We've done a great job putting together a very fantastic group of speakers here today. So we are looking forward to learning from all of you, from your various countries and your environment and your experiences. I think we can now move forward to our very first speaker, so that we stick to the agenda as presented, and then for the time that we have, we try to make the best of this and get a lot out of this webinar. So our first speaker is Dr. Kate Sabin of UNAIDS. Dr. Kate is a senior advisor for epidemiology with the Strategic Information to End Inequalities, SII team, of the Data for Impact Department of UNAIDS. He is also the acting team lead for the SII team. So he will be taking us through HIV incidence trends, estimates and trends, distribution and patterns. Dr. Kate, you're very welcome to this webinar. Are you there? Can you hear us?
I am here.
Fantastic. So you may now begin. Let's take your section.
All right. Thank you, everybody, and welcome to this webinar. I will attempt to walk through this. It shouldn't take me the full 20 minutes. So let's just dive right into this. For those of you who are familiar with UNAIDS data, many of these figures will look familiar, and if not, everything I present today is available already on our website at aidsinfo.unaids.org. Next slide, please. So overall, we're doing pretty well. New infections are declining globally, but really we're not moving fast enough to achieve the targets that have been set by the global community. Similarly, we're closer to our target when it comes to AIDS-related mortality, but again, we're on a trajectory that will have us falling short unless we can improve the AIDS response, the HIV response globally. Next slide, please. Now, for that success, we're not seeing it distributed equally across the world. So here we have the regions of the world as defined by UNAIDS. Every organization has its own definition of regions. But what we're seeing very clearly is that Eastern and Southern Africa, Western and Central Africa are by far doing the best in terms of reducing the number of new infections annually. And the other regions are either doing less well, or in some cases, they're beginning or continuing to move in the wrong direction. Now, while the epidemic in the Middle East and North Africa is clearly expanding, it's still a relatively small epidemic. But if we don't intervene there in the near term, we're going to have issues in the longer term. Next slide, please. Now, different countries some countries are doing exceedingly well. And this is I think this is very gratifying for those of us working with these particular countries to see how much decrease they're experiencing in the numbers of new infections. We can see Zimbabwe is leading the way, followed by Nepal, Lesotho, Rwanda, etc. So clearly we're doing well in a number of countries who have, at least with Nepal's presence here, it's it's not just these broad general epidemics, but it's also at least one country where the epidemic is concentrated primarily among key populations and their partners. Next slide, please. Now, one of the major components of the success of the AIDS response, HIV response, is the impressive level of treatment scale-up. And you can see here, comparing 2015 in the orange to 2022 in the green, that the number of people living with HIV who know their status, who have had an HIV test and have received that result, has increased by 15 percentage points. We see ART coverage is increasing even more quickly. And then for once people who are on ART, we find that viral load suppression follows shortly thereafter. Now, in terms of the numbers that we generate, this has a tremendous impact on reducing new infections. Prevention services and related ancillary services to prevention are also critical in the successes we're seeing in the reduction of new infections. So next slide, please. And just to be clear that not everybody is experiencing ART, the treatment cascade, at the same levels. So here, when we look at the total population, which is in the left-hand column closest to the country's names, and then compare that to men and women in the next two columns, and then children in the final column on the right, we can see that women have all the darker shade of green, which means they have achieved the 95-95 treatment targets or close to it. Whereas the lighter shades of green are countries where men are further behind in terms of accessing treatment successfully. And then, unfortunately, children, we see too many countries in white. Denmark is grayed out because in Western Europe, we don't have those data for children. So by gender and by age, we are having differential success and challenges, and these are things that remain to be addressed in the HIV response. Next slide, please. Now, many of you may have seen these slides before. This is from a paper, the source is cut off at the bottom of the slide, but this is from a Journal of AIDS article that came out in a special supplement in January of this year. You can go read that if you like. It is open access. Now, this shows in the outer ring of these circles is 2010, and the inner ring is 2022. And you can see the changing distributions of where new infections are occurring. So we're seeing globally this shift toward gay men and other men who have sex with men, and much of that change is coming out of what we refer to as the remaining population. That's men and women with no known or no reported risk. But even with this, we see very different experiences when we look at the data regionally. Have the next slide, please. And the number of new adult HIV infections has all that success that we're seeing is occurring primarily in West and Central Africa and East and Southern Africa. And here it is numerically, it's the same data that informed the proportional change from the earlier slides. So what we can see is, if you look carefully, the top two colored bars, the dark red and the dark blue, represent sub-Saharan Africa. And almost all of the change between 2010 and 2022 occurs within those two bars. And then if you look at the rest of the regions, beginning with the orange and working down, those two figures have barely changed between 2010 and 2022. So keeping that in mind, let's move to the next slide, please. Here is the distribution by subpopulation within sub-Saharan Africa. And we see very little change among the distribution of new infections among key populations as it relates to those among the remaining population. We see a little bit of an expansion, we see a decrease in the number of new infections among clients of sex workers. We see a smaller decrease among sex workers. And these decreases are not statistically measurable, so we can't tell you if they are statistically significant or not, but they're changes as we've determined it through the modeling that we've done. And if we take the next slide, which is the rest of the world, outside of sub-Saharan Africa, we see a distinct change occurring, where the remaining population has a much smaller proportion of new infections in 2022 as compared to 2010, and an expanding proportion of new infections are occurring among gay men and other men who have sex with men. Keeping in mind that the denominators for both circles here are the same. So these changes are the same in absolute numbers. If the bar is bigger in the circle, it means the absolute number is also bigger. Next slide, please. And what this means is that when we compare these populations to the entire picture, the total change in new adult infections, which is represented by the red bar, the red horizontal bar across the figure, that some populations are benefiting, or at least in our models, are benefiting equally from the expanded ART and prevention programming, but some populations are clearly not doing as well from those changes, particularly men who have sex with men and transgender women. Next slide, please. That's the global picture. We can see in outside of sub-Saharan Africa, whereas the total adult population outside of sub-Saharan Africa has experienced very little change. It's nearly 0% change. And among key populations, most of them have experienced an increase in the number of infections that they're experiencing. And the next slide, which is showing the sub-Saharan Africa, where we're seeing this across the board experience, which may be attributed to the fact that sex workers are experiencing ART, the benefits of ART cascade results in the same proportion as their female counterparts in the rest of the population. We don't know if that's true, but that's what the model is assuming. So next slide, please. Yeah. That's it. Again, I would encourage you to look at the paper to get a clearer understanding of what we found. And the data are available for you to look at in a supplementary data set for those of you who are so inclined. So I'll turn it back to our moderator.
Thank you so much, Dr. Keith. That was truly an insightful presentation with very important data. The data you have presented, again, re-emphasizes the importance of this webinar, which is really to draw attention to focus groups and vulnerable groups, and then try to modify our programs to focus our resources and pay more attention to the groups that are contributing the most to new infection. I'm assuming you will be sharing these slides after this meeting, considering the time limit that we have, so that we can better benefit from your slides. I think that we have perhaps 1 or 2 minutes for questions, if we can take questions quickly. Dr. Keith, I hope you're open to that. If we can take 1 or 2 questions, since we have some time left from your slot. You have 20 minutes left. We have about 10 minutes left. So we can take 1 or 2 comments or questions from the participants online, please. So if you have any questions, comment, please raise your hand quickly. Or type it up in the comment section so we can read it out. Questions, comments?
Dr. James, there are some questions in the Q&A box. I wonder if you want me to read them out for you.
Okay, I see a hand raised. Let's see. No, not me. So, Dr. Peter Mudiope, sorry if I don't pronounce her name very well, but
Thank you, Dr.
Peter,
James.
you have the
That's
floor.
my name, Dr. Peter Mdiope from Uganda. Sorry, I didn't
Okay.
put that. Thank you, Keith, for this presentation and always being there to enlighten us about this. Just a quick question because of time and we have a lot to discuss. I think we need more TA in country because when I look at these figures, yes, there is a general picture demonstrating the increase of sex workers, uptake, and then reducing infection. But I still see in the general population or the rest of the population, there are quite a number of priority population that may not be really unpacked, that are responsible for these new infections, and we may carry them as a pack of general population or other population, which may be even more critical than the population categories we are looking at the moment. But I think we need some TA to unpack that population category. Thank you.
Thank you so much, Peter. Any other comments? I think that was more of a comment than a question, really. Any other comments, questions? We still have about 5 minutes.
James, I'll respond quickly to my good friend Peter's comment. And that is, I think if there are other populations that at increased risk that we need to pay attention to, a good place to start would be in the FIA if they are populations that would be captured within a household survey. Most of the key populations, the information that would identify them within a household survey is often missing or poorly reported. So we have to look at their data somewhat separately. But there are other things we can do if there are other populations we need to identify.
Sounds great.
I'll answer the questions in the chat, within the chat, because there are a bunch of them.
So let me look at the chat box, see what questions we have, if any. Okay, so I don't see any questions in the chat box. All right, Dr. Keith, well, thank you very much for your time. We'll move over to the next presenter, which will be, I have two listed presenters here, is Dr. Moyo Online from Botswana Harvard Health Partnership.
Yeah, I'm online.
Okay, Dr. Moyo. So Dr. Moyo is a research scientist and medical virologist based at the Botswana Harvard Health Partnership and a research associate with the Harvard T.H. Chan School of Public Health. Dr. Moyo Sikulile is a member of the steering committee of the Phylogenetics and Networks of Generalized HIV Epidemic in Africa Consortium. So, Dr. Moyo, we are very privileged to have you. I will stick with that name if you don't mind, because the first one is a little bit difficult for me to pronounce. So, pardon me. So, Dr. Moyo will be giving us insights into factors associated with incidents, factors associated with incidents, insights from phylogenetic, and then long-term projections. Dr. Moyo, you have the floor.
Thank you. Thank you so much for the opportunity to present some of our work. If I can have the slides, please. I'm presenting on behalf of the Pangea Consortium. Next slide. As the Pangea Consortium, in this session, we'll try and see the role that can be played by phylogenetics for public health interventions. Pangea Consortium is a consortium that is funded by the Bill and Melinda Gates Foundation, and it brings together scientists in Africa and abroad, and institutes that are planning the areas with the highest case burden in East and Southern Africa, which you see on the map. If you see on the map, you see the areas that have the highest burden in red. And we have brought together research cohorts, importantly, and programs as well, with the unique capacity to do high-depth HIV genomic sampling within these high-burden areas. And importantly, and also simultaneously collect detailed corresponding epidemiological metadata. I think that's very important, that we're combining both phylogenetics, but also classical epidemiology. And oftentimes, genomic data is not associated or is not put in context, which is sometimes we actively address these questions as part of the consortium design. We want to put the data in context within the changing profile of the epidemic. One of the central objectives of Pangea HIV has been to identify epidemiological drivers of transmission at a population level, looking at whether you have sinks or sources or amplifiers of transmission. And importantly, within the changing phase of the epidemic, we use additional tools like deep sequencing and phylogenetics and modeling with the goal of ultimately understanding how we can better target HIV control efforts. As a consortium to date, we have generated HIV deep sequencing data from more than 30,000 unique individuals over the last decade, and also generated tools and building capacity in a number of African countries to be able to do this analysis as well. Next slide, please. So how do we use phylogenetics? When you sample blood from study participants or from a program perspective, when you analyze their viruses, you can determine who is likely infected whom, and learn more about the sources of infection and quantify, most importantly, the tools we have generated is at least be able to quantify the patterns of transmission in a given population. As you can see, the deep sequencing data on your slide, we can infer by looking, by calculating generation time or looking at time to the most recent common ancestor. We can see in this picture that we can infer that person A most likely transmitted to person B. And also, next slide, please. And also, we are able to get information about age, recency of infection. We can calculate the time that is taken from when the inferred ancestral virus is found in person A, and also the inferred ancestral virus is in time B, and also when person A could have been the source of transmission for person B. Next slide, please. So we are able to look at the time course of infection and also estimate the time since infection for the recipient. Next slide, please. So one of the key findings from the Pangea network that we have seen from our data is the age of infection is increasing. We see a disproportionate contribution of some age groups, especially men, in terms of onward transmission. We've also looked and quantified transmission sources, and we see that 63% of the transmissions from people infected more than a year ago, meaning that it's important to keep the individuals on ART and suppressed because they still contribute to onward transmission, other than focusing on only individuals who are infected within 1 year. We've also looked at the clusters that we've identified and characterize the clusters across the East and Southern Africa. I'm going to draw your attention to that. And also, most importantly, monitoring drug resistance, which is very important, especially in the era of dolutegravir. Next slide. I've already mentioned about the changing profile and of age. Here is data from Uganda, just definitely showing us that the age of infection is increasing. Next slide. What we've also quantified in this graph that you see here, data that we have taken from one of our studies, HPTN 071, looking at, you can see the data that you see there is the relative likelihood of being a transmitter as a proportion of all persons living with HIV in the top panel, and the proportion of all persons living with HIV not on ART in the bottom row. And you can see that if you look at the blue lines of men having much higher likelihood of being classified as being a transmitter, given their proportion in the population. And particularly, you can see that likelihood is really increased between the ages of 25 and 40. Next slide, please. We also highlight that closing gender disparities could be very, very important. And if you look at the small number of men treated, if you look at the red color there, achieves 50% reduction in female HIV incidence. So focusing on men could have a real impact in reduction of incidence in the female counterparts. Next slide. And also we looked at sources of transmission and also the fraction of transmissions, and we demonstrated that 63% of the transmissions actually originated from chronic infections. So which means it's very important to really focus on viremic individuals when it comes to onward transmission as well. So both early testing and retaining people in care becomes very crucial. Next slide. This is the distribution of cluster sizes in all our cohorts. And you can see at the bottom is the cluster size, and the axis shows the proportion of clusters. And definitely across all our cohorts, this data is replicated and show that we have very small cluster sizes as compared to what you see in Europe and elsewhere. The cluster sizes are very small. So that has an impact in terms of how do we target prevention, since we are not seeing these high clusters. And also we need to look at this data, and are we looking at the right places, which is very, very important. Next slide. Next slide. So this is this data showing the distribution of the clusters. Previous slide, please. Previous slide, please. This data shows the distribution of the clusters. If you look at the Dutch MSMs and you look at the UK MSMs, these dots that you see in red indicate HIV sequences that represent individuals who are in a transmission chain or in a cluster. But if you look at the Pangea combined data of 18,000 sequences, you see very small cluster sizes, often between 2 and 3. The largest cluster that we ever observed from Uganda had 12 individuals, mostly dyads with 2 individuals to 3 individuals, very small cluster sizes as compared to what you see elsewhere. We've also been, next slide, we've also been looking at drug resistance. Next slide. My slides are not moving nicely, but I just wanted to highlight to you the good news about drug resistance. But we see that before the era of DTG, we saw an exponential increase in some of our communities in Zambia, which is very important. And now within the era of DTG, it means that we really need to be carefully monitoring the emergence of drug resistance, especially to DTG. We have preliminary data, some of our studies in Uganda, for instance, showing some early signs of possible increasing drug resistance to DTG. Thank you. With that, I would like to thank the Pangea Network. Next slide. Next slide. I'd like to thank the Pangea Network for all the work that have done in the field, the participants involved, the ministries of health that are involved in partnering with all these studies, and the fund and the generous funding from the Bill and Melinda Gates Foundation. Thank you.
Thank you so much, Dr. Moyo, for that interesting presentation on phylogenetics. Please, before I go on, let me quickly also take the opportunity to introduce your colleague as listed as a co-participant here, Dr. Jeff Ima-18. Dr. Jeff is an associate professor of epidemiology in the Center for Communicable Disease Dynamics at the Harvard T.H. Chan School of Public Health and senior research fellow at the MRC Center for Global Infectious Disease Analysis at Imperial College London. He co-chairs the UNAIDS reference group on HIV estimates, projections, and modeling. Dr. Jeff, you're very welcome. And thank you for making our time to be part of this very important webinar. Before I take a quick comment, since we have some time, I'll take some comments and questions. But before I do, I'd like to thank those online that have, there's a couple of questions posted online with specific requests for the answers to be typed. And I can see Dr. Keith is responding to those questions. So I will quickly open up the floor for comments and questions on this section. We have about 15 or so minutes to quickly discuss and ask questions. Phylogenetics is not one of the most popular areas amongst in HIV/AIDS responses, but very important nonetheless. So I'm sure we have a lot of questions. So I will open the floor for comments and questions. So please, you can just raise your hand if you have questions, or if you have questions, you can also type online, and then we'll take it from there. Any questions, comments, please?
Jackie, you're unmuted.
I don't see any hands up.
Hello.
Okay, I'm trying to see.
Jackie, I think we can hear you. Dr. James, I think his hand is up.
Thank you. I just wanted to ask, what is the limitation of the phylogenetics? So how many iterations of an infection or how many branches, up to how many branches can it go to before you start losing sensitivity or accuracy? Over.
Okay, we can take a response from Dr. Moyo or Jeff before the next question, please.
I don't know if I understand the question, but I think with deep sequencing data, the question that is being asked, if you have deep sequencing data and high enough depth to be able to reconstruct the time since infection or the TMR-CA with some level of confidence. We always attach confidence to the time estimates, and you want it to be as tight as possible. And of course, you can see a well-supported phylogeny and not a well-supported phylogeny. And so you only be able to get good estimates when you have a well-supported branches. I hope I'm answering your question. There are some cases where you don't have enough deep sequence data to make a conclusion, or the confidence interval of the time estimate is too wide. So there is that noise. But if you sequence deep enough with the methods that, for some of the methods we do, you are able to narrow that time as much as possible by reconstructing the time to the most recent or the time of the introduction of the virus to that particular individual. Thank you.
Okay, Jackie, I hope that answered your question. There is a question online for Dr. Moyo and the team. The question is how generalizable? Oh, okay, the question just disappeared. Let me look for it.
Yeah, I think I saw the question from Yogan Pillay. The question really was, thanks for the presentation data. It was talking about how generalizable are the results from cohort studies and that you report on. I think that's an important question. In most of the studies, for example, we have sampled very large number of communities. In Botswana, for example, it was 30 communities spanning across the entire country. In Zambia as well, very large communities representing different spectrum of the epidemic. And in Uganda, they've been following cohorts for a long time. But we understand that we may be missing some core groups. Some of the work that we are trying to do now is to really put innovative designs of making sure that we capture the right people. Why are we seeing small cluster sizes? Is it because we are not looking in all the places? And those are some of the questions that we have going forward, and particularly looking for viremics and new infections and testing how phylogenetics could be able to improve precision public health.
Okay, that's great, Dr.
Dr. James, I think you muted yourself.
Hello, Dr. Jeff. I said we'll quickly take your presentation now. I'm sorry, I think I was muted. We'll quickly take your presentation now, so the floor is yours.
Great, thanks so much. So now I'm going to talk a bit about building on the trends, the recent trends that Keith presented, and some of the current transmission dynamics that Sikulile presented, to talk about some mathematical model projections and some of the things that they tell us about how the epidemic is changing and what some of the priorities might be for HIV programs, emerging priorities might be for HIV programs in the future. Next slide, please. So a few of the key messages that we'd like to take away from this are, firstly, based on mathematical model projections, we anticipate continued decline in HIV incidence if we continue active programs that sustain our current levels of treatment, diagnosis, and prevention coverage. But we expect that those declines in incidence might slow a bit compared to what we've seen over the past 10 years or so. One of the key features that we see is the population with HIV is aging very rapidly, and we need to be thinking about the implications of this for both our HIV treatment programs and meeting the needs of an aging HIV population, as well as for HIV prevention programs and how this aging HIV population is changing who's exposed to risk of acquiring HIV infection. As Sikulile just described, we require HIV prevention strategies that are capable of reaching large populations with relatively moderate HIV risk. And to help us guide that about how we need to adapt our prevention strategies, that we should think about following the virus, focusing on adapting our prevention strategies by identifying where in the population the people are with prevalence of unsuppressed HIV. And then lastly, to reinforce the message that epidemic control requires active long-term intervention efforts to sustain the progress that we've had over the past 20 years in the HIV response. Next slide. So first, regarding future trajectories of the epidemic, this is work by the HIV Modeling Consortium, a collaboration of mathematical modelers and HIV programs in 3 countries, South Africa, Zimbabwe, and Malawi, that looked at, as a first step, projecting forward, if we maintain current levels of treatment coverage and viral suppression, as well as HIV prevention, how will new infections change in the future? But we can see in all three countries, the models projected that HIV incidence would continue to decline over the period from 2025 to 2040, but the rate of decline was somewhat slower than what we experienced over the past decade or so. Next slide, please. And in terms of understanding the reason for that change in the rate of incidence decline, it's helpful to reflect on how the proportion of the population with HIV viremia is changing over time and what's driving that change. So over the past 10 or 15 years or so, or from 2010 to 2020, we had really rapid ART scale up that led to rapid reductions in population viremia that drove down incidence very quickly. Over the next 15 years, we expect to continue to see steady decline in prevalence of viremia in the population, but most of that decline now, as we're at or near 95, most of that decline will be through reducing HIV prevalence, driving continued reductions in new infections, but that declines at a somewhat slower rate than what we've seen over the past decade. Next slide, please. Another important message that comes from our epidemiologic data is thinking about how we can target our HIV prevention strategies. And so this is evidence from a systematic review of HIV risk score papers that have tried to identify consistent predictors of HIV incidence and see if we can, the extent to which we can use those predictors to identify the population groups at highest risk of acquiring HIV infection. And overall, what we see in the literature is that there are consistent predictors of HIV incidence, including non-cohabiting with a primary sexual partner, young age, having a curable STI, having HSV2 infection, or having multiple partners. But together, these predictors only had low to moderate ability to differentiate those who subsequently acquired HIV. So for example, if we wanted to identify 75% of new HIV infections, we would need to classify between 40 to 65% of the population as at high risk for HIV infection. Next slide. So how can we think about adapting our HIV prevention programs and to a shifting epidemic? One of the key messages here is to adapt HIV prevention strategies through focusing on where there's prevalence of unsuppressed HIV. So now we're just going to talk through a few examples of that. Next slide, please. So one example is the implications of our aging HIV population. You see that over 2010 to 2025 to 2040, the median age of someone living with HIV in our region is increasing really rapidly from around 30 years in 2010 to 42 years in 2025. And that's going to increase to 54 years by 2040. Next slide, please. And that same aging of the epidemic also affects where the viremia in the population is changing, and that's also aging. Next slide, please. So as the age distribution of people with viremia ages, the age of their sexual partners is also going to age, and that's going to mean that we're going to see, instead of seeing new HIV infections very concentrated in young adults, we're starting to see HIV infections, and increasingly in the future are going to see HIV infections spread across all age ranges. And so we need to be thinking about how to adapt and extend our HIV prevention strategies to this increasing age range of people who are potentially at risk of HIV infection as viremia ages in the future. Next slide, please. Another example of following the virus to adapt our prevention programs is through geospatial analysis. We know from really strong evidence now, including from the FIA household surveys, as well as from the universal test and treat studies, that most new HIV infections occur in communities with high prevalence of unsuppressed HIV. So a combination of high HIV prevalence or high HIV burden and potentially lower treatment coverage and viral suppression. And so these are areas that we can focus on to prevent the most HIV infections. Next slide, please. Thirdly, as we've scaled up and increased our treatment coverage, we're also aware of the gaps along the care cascade. And as our population has shifted from large numbers of undiagnosed and untreated people to people who are treatment exposed, we're also seeing an increasing share of HIV transmission amongst people who have interrupted treatment. And so increasingly focusing on, of course, continuing to diagnose and treat people with new HIV infections or who haven't been treated, but also focusing on people who have potentially interrupted treatment or are not virally suppressed as an important population that we need to reach in order to reduce new HIV infections in terms of where viremia is in the population. Next slide, please. And then lastly, just to think a bit about what the future course of the epidemic looks like. And here we're using mathematical model simulations for South Africa from the Tembisa model. And the key message here is that sustaining HIV epidemic control requires continued intervention measures. So these are model projections using the Tembisa 4.5 model out to 2100. And the model projections show us that if we continue our current levels of HIV testing and prevention in South Africa, we project that HIV incidence will continue steadily declining for many decades to come, down to a very low level beyond 2050 and into 2100. Next slide, please. Now, this is zooming in on our HIV incidence trajectories about what might happen if we start to scale back some of our prevention interventions that we've implemented thus far. So the red line here is that same if we continue our current prevention. Then if we discontinue pre-exposure prophylaxis amongst high-risk populations, incidence continues to decline, but may settle at a slightly higher rate. If we discontinue pre-exposure prophylaxis and voluntary medical male circumcision programs, then we can see again, incidence continues to decline for several decades, but doesn't reach that very low level of incidence that we might otherwise achieve. And if we have a combination of scaling back of HIV prevention and reductions in condom use in the population or other increases in sexual risk, we could start to be concerned about a stagnation of our incidence declines and incidence continuing at a rate that might be unsustainable for the HIV program and to reach our targets. Next slide, please. And lastly, to think about where we get kind of short-term and long-term impacts from our program, here we looked at what happens if we were to continue our current prevention programs, but also improve linkage and retention in South Africa to attain the 95-95-95 targets by 2030. And in that case, if we attain 95-95-95 rapidly, then we get much more rapid declines in HIV incidence and really drive down HIV incidence up to 2030. If we were to attain 95-95-95, but at the same time discontinue some of our prevention programs, our PrEP and VMMC programs, we still get that rapid reduction in incidence from reducing population viremia, but over the long term, incidence settles at a higher level. And just kind of shows us that maintaining these prevention programs is important for the long-term maintenance of epidemic control. Next slide, please. And so just to summarize some of the priorities for HIV programs to sustain epidemic control. Firstly, effective treatment is really the cornerstone of our sustained success. We need to maintain extremely high treatment coverage, retention, and undetectable viral load, really empowering individuals for this through U=U, bringing an alignment of individual health and our population epidemiological outcomes. Second, we need to continue to focus on timely diagnosis, rapidly attaining viral suppression or to limit transmission opportunities, ensure that we have easy access to HIV testing, combined for everyone who needs it, as well as high rates of testing amongst population with elevated HIV risk. We need to adapt our HIV prevention, anticipate evolving individual needs and preferences as the risk environment changes, and really follow this message of follow the virus to identify how we need to change our programs. And finally, as was emphasized by Keith at the start, we need to ensure that we maintain key population services, both prevention and treatment services that meet the distinct needs of populations and need to be sustained in perpetuity for these populations. Next slide, please. I also just acknowledge a very large number of epidemiologists and mathematical modelers who have contributed evidence to the collection of work that we've seen here. Thanks very much.
Thank you so much, Dr. Jeff. Truly appreciate that. You stayed within the given time for your slot. I truly appreciate that. I was already looking at my time, but that's fantastic presentation. I see a few hands up. We have just about 2 or 3 minutes before the next section. I saw a hand up, but perhaps it's an old hand. So any quick question for Dr. Jeff? Any quick question before we go to the next session? We have just about 2 minutes. Okay, I see a hand up. Let me see who this is. Okay. Kensani, go ahead, please. I hope I pronounced your name right.
No, it's okay. Good afternoon, everyone. My name is Kensani. I just wanted to get clarity on that slide where you were showing the different interventions that can be implemented. Are you saying that even if we don't continue implementing, other interventions, but we focus on treatment, the HIV prevalence will still go down? Or I didn't hear you clearly. And if it goes down, by what rate are we looking at?
Yeah, that's right. So through rapidly scaling up treatment and viral suppression, we do get rapid declines in HIV incidence because we're reducing viral load suppression. And so that's a very important intervention to control new infections quickly. But what we also see from the modeling is that alone, at least in the South Africa case that we're modeling here, doesn't get us to the long-term very low level of incidence that we desire. And so we need to balance both continuing to scale up our treatment of viral suppression, but also sustaining some of our core prevention strategies that have been important for the gains we've seen thus far, and therefore will also be important to keeping infections low in the future. And it's not prescriptive about exactly which interventions we need, but we need to maintain different levels of interventions at the right levels to keep incidence controlled.
Okay, great. So that's our time for this session. Dr. Jeff and your team, thank you very much. Dr. Moya, thank you so much. While you remain online, I think there are a few questions that require you to type in. For example, there's a question from Godfrey that says, hi, Jeff, where is South Sudan standing regarding these trends? But anyway, he's requesting for you to type in the answer. So I'm going to move on to the next section. Thank you once again, Jeff. And thank you, Dr. Moyo, for this session. Thank you all so much. So we'll move on to the next section, which is also a very interesting session, which is one of the primary reasons why we're here. How can this data be used for HIV prevention, policy, programming, and prioritization? The case study from Mozambique on the SHIP project. And to do justice to this section, we have Dr. Clemens Benedict, who is a senior advisor for the HIV Prevention Coalition at UNAIDS. Since 2018, he has worked with the Coalition on Prevention Analytics, knowledge products, strategic guidance, and country support. Dr. Clemens Benedict, you're very welcome to this section. Also part of this session is Dr. Sandra Goncalves. I'm not sure if I pronounced that well. My apologies if I didn't pronounce her name well. So Dr. Sandra is currently supporting the Mozambique UNAIDS country office as the antenatal care data quality advisor since 2023. She's a demographer with over 10 years of experience working in health information system strengthening, reproductive health, UNAIDS program monitoring and evaluation, statistical data analysis, and building MIE capacity. So Dr. Clement and Sandra, the floor is yours. So we'll be taking a look at how this data can be used for HIV prevention policy, programming, and prioritization. Case study from Mozambique. The floor is yours.
Thank you so much. And I'll just be quickly looking at, how can we use HIV incidence data for programming? Next slide, please. And we have actually a track record in the AIDS response of not having used HIV incidence data as much for prevention policy and programming as we could have. And the COVID response actually made incidence a concept that is even more widely known in society. And this is really a call on us to use, as HIV prevention programmer, the wealth of information available more actively for informing prevention decision-making. Next slide. And what we have actually is a very strong mandate from the global community. At the level of the General Assembly, the heads of states, we have set a target, a global target, to reduce new HIV infections to fewer than 370,000. And actually that translates into an 80% reductions in new HIV infections by 2025. And this is really a strong mandate for us to focus on incidence in our decision-making. Next slide. What we've already heard is we have a global trend of declining HIV incidence, in particular in Eastern and Southern Africa and Western Central Africa. And here you see, and some colleagues have asked in the chat, different trends for different countries. And we see here, to achieve an 80% target, countries should have achieved a 66% reduction, a more than 66% reduction by 2022. And there's 9 countries in the Global Prevention Coalition on track with that reduction. The largest number of countries is in a group making moderate progress, so need to accelerate to achieve that target. But there's also a number of countries with limited progress and countries with rising HIV incidence. So in using that data, the starting point is really to understand, where does your country stand in terms of progress? Is there need to accelerate, or is there a need to actually achieve a turnaround? Next slide. So we have this tool that will see the Mozambique example, but maybe I'll just give a few overarching remarks. So we have a tool for subnational HIV incidence estimation in priority populations developed through the Global Prevention Coalition with support from various partners, including the Global Fund Data Strategic Initiative and the Gates Foundation. So we have available subnational estimates for countries in sub-Saharan Africa, and you see them listed here, and you have the link to this information, which is a very detailed and very large spreadsheet that can be accessed. Next slide. So the tool has different outputs: behavioral, population information, population sizes, estimated new HIV infections and incidence rates, and both absolute numbers here and rates represented. Next slide. And here we just show the logic of this tool. So it differentiates between different levels of HIV incidence, from low HIV incidence defined as less than 0.3%, very high HIV incidence with more than 3%, and then different sexual risk categories, including no sexual risk, regular partner, non-regular partners, and young key populations being the highest risk categories. Next slide. What we see actually is striking differences in HIV incidence rates on the African continent. If we look at the woman with a non-regular partner in Western Central Africa and the young woman at highest risk, for example, selling sex in Southern Africa, we see a 1,000-fold difference. And we also see here that actually, if we look at the continent at large, we do not have very high HIV incidence rates in most places except Southern Africa. So we have actually only very high incidence rates among young women selling sex in large geographies. Next slide. And then if we look at the tool, we have these kinds of outputs, as you see represented here. And we look again in more detail at Mozambique. But what you see here is actually HIV incidence rates, in this case, in Malawi, disaggregated by location, age, sex, and then behavioral risk categories. And when we look at Malawi, a country with relatively high HIV prevalence, we see even here, we look at the population at large, HIV incidence rates distributed across the country and populations. In most populations is relatively low. We see elevated HIV and highest incidence among young women and adult women selling sex, particularly in southern Malawi. So there's a geographical distinction here. And among the other populations, we see higher incidence rates among young women with non-regular partners, particularly in the 25 to 34 age group, where we have, in this setting, actually the peak in incidence. But it's important not just to look at the rates. And in the next slide, we see actually the absolute numbers. And that gives us, again, a different picture that shows that in terms of absolute numbers, the largest numbers of new infections are actually among women with non-regular and regular partners, again, in that 15 to 24 to 34, 25 to 34 age groups, so young adult populations accounting for the bulk of new HIV infections. And what it shows us is we have two considerations here. So small populations at relatively high risk and large populations accounting for the largest number of new infections. And that's important to understand in prevention programming and aligns to the fascinating presentations we saw from Dr. Moyo and Jeff Eaton just now. Next slide. And then we have the same outputs down to district level. And this is just a district level example from Zimbabwe. Next slide, where you then have the population sizes in the district associated with these populations with high incidence. Next slide. What then the suggestion is in terms of using this for prevention programming is that one would differentiate in terms of the intensity of prevention programs, high levels of incidence. So in low incidence settings, we would still have testing and condoms available. We would have key population programs and people living with HIV on ART. And then with moderate incidence, one would scale up demand generation, first with low-cost virtual and media modalities. One would add active promotion of PEP. In high incidence settings, then really have interpersonal face-to-face outreach, and in the very highest incidence, subpopulations and settings, adding PrEP. And of course, not being exclusive about this, and this is what the arrows suggest here. So we add additional interventions with increasing incidence, but at the same time, for individuals, even in lower risk categories that have particularly high risk, we are open to make available in higher intensive interventions like for example outreach or PrEP. Next slide. So, and of course the key message here is that the thresholds are just broad guidance and not to be taken exactly. So in country you have flexibility, of course. This is not rigid guidance. Next slide. And there's additional guidance available from a decision-making aid then how to engage people in those categories. For example, where can we find, based on the incidence information, young women, for example, with non-regular partners in contraceptive services, in higher risk venues. And there's a methodology to do that proposed here. Next slide. Important to consider this, of course, in the context of factors associated with HIV incidence, behavioral, biological, and structural, and then prioritize among those. There's guidance on this as well. Next slide. And for key populations, of course, important at country level. For example, in Malawi, we took 1 hour just to look at those incidence distributions to understand them and engage stakeholders in interpreting them. Next slide. And I probably jumped this because Jeff has covered it already, but with reaching a small part of the population, we can actually achieve a considerable success in or progress in reducing a much larger portion of new HIV infections through using this HIV incidence information. And there's also other decision-making tools available, like the models that Jeff already showed. And I won't go into detail on this and end on the last slide here, which the next slide is, which just, we can even go to the next one. This one just outlines the dimensions of differentiated prevention. So prevention being people-centered on the one hand. So we don't use this information for excessive individual screening, but use the information on HIV incidence in the design of prevention interventions. And what it points to broadly is very much aligned to what we saw from the modeling presentation. We will need a mix looking forward at intensive prevention for populations with highest incidence, so those small populations, and basic lower cost prevention options at scale for the larger populations with moderate. Thank you.
So thank you very much, Clemens. I appreciate that. We are running a bit behind on time, just a few minutes behind time. So Sandra, please, if you can save us some time and just give us highlights, please. I'm sure we'll get a chance to see these slides afterwards. Thank you. Go ahead.
Okay. Good afternoon, everyone. And so to give the case study from Mozambique, next slide, please. So just in general, Mozambique is one of the countries that has a high HIV burden. We have the third largest population of people living with HIV. And when we look at our young people that are aged 15 to 24 years, particularly adolescent girls and young women, you find that they make up 10% of the population, but they're actually responsible for 30% of the new infections in country, which makes them a very key group, important group in terms of HIV prevention efforts. Next slide, please. So in 2020, the government-led Adolescent and Strategic Information Technical Working Group conducted a district prioritization exercise specifically for adolescent girls and young women. And from the map, you can see we see an overlay of HIV incidents, AGYW HIV incidents that was obtained from the Naomi model, and it's overlaid with AGYW programs, so partner presence. And just looking at the map, you see the more darker blue districts. The country has a total of 161. So the more darker blue districts that some of them do not have the icon that shows a program or a partner presence. Next slide, please. So just from that analysis of the overlap of the mapping, the technical working group was able then to actually recommend an expansion of AGYW programming from 62 to 101 high incidence districts in 2021. And just to remember that 78 of these districts are supported by the Global Fund. And so in 2020, the future outlook at that time was to apply this methodology to key populations, but also there was the need to have population size estimates for better prevention efforts. Next slide, please. So in 2023, as Clemens was presenting, the SHIP tool was made available, and it was used by the Mozambican Technical Working Group for AGY district prioritization, specifically for the Global Fund proposal GC7. And so just in broad terms, the first step was to use the SHIP tool to update HIV incidents, district categorization. So were there any changes in terms of partner presence and high HIV incidents? And what we found was there were 6 districts that did not have any programs. So we're looking at the main programs, thus the DREAMS funded by PEPFAR and Viva Mais, which is funded by the Global Fund. And then because the tool does not include other vulnerability risk factors, the group had to actually look at them individually. So for example, we have school dropout rates, proxy for teenage pregnancy, and this is data that was received from the Ministry of Health and the Ministry of Education. And then lastly, in this district prioritization exercise, we also reviewed health facilities for expansion of what we call adolescent-friendly health services. And these are like services targeting adolescent and young people. Next slide, please. So this is really an excerpt from the tool, and it's just showing, and I won't go into details because Clement spoke about it, but it's basically the last column to your right is just showing the incidence categories with the color coding, where the dark orange is for very high incidence and the pink is for high incidence. And so when we look at the behavioral groups, we see that the high incidence is in the female sex workers, which are the key population, and those that are in the non-regular population behavioral group. Next slide, please. And so the technical working group used the SHIP tool, and we can see on this slide outputs that were produced. We have a map that's really showing HIV incidence for HYW, and you can see that most of the dark blue, which is the high incidence, is in the south of the country or along the coast or in districts that are bordering with the neighboring countries. Next slide, please. And so this whole analysis using the data that is in the SHIP tool led the technical working group to prioritize 82 districts for the Global Fund 2024 to 2026. And basically, these 82 districts were composed of 76 that had been prioritized in 2020, plus an additional 6 districts. And these were 3 high incidence and 3 moderate, based on the analysis of vulnerability, but also looking at high incidence and other factors. Next slide, please.
You could please round up in 1 minute, Sandra, please.
Sure. Next slide, please. Great. So after the district prioritization, we also apply the tool to target setting, and the indicator was to estimate percentage of high-risk adolescent girls and young women that were reached with HIV prevention programs. Next slide, please. And basically, in this case, we defined high risk based on the SHIP tool population behavioral group categories, and high risk were defined as adolescent girls and young women in the non-regular multiple partners and in the key populations. Next slide, please. We basically just use the tool to be able to estimate the denominator, which is the sum of all the 82 priority districts. And for the numerator, which is the target reach, this was a 95% target reach based on the global prevention roadmap. The next slide, please, just to round off the next one. So basically, this is just showing the district targets, which is another advantage of the tool because it actually allows programs to be able to see what are the targets at district level. And then in terms of next steps, as the last slide, so after we use the tool to be able to prioritize districts, to be able to set targets, the next kind of thinking or discussions is around strengthening HIV vulnerability through improvement of the vulnerability assessment tool, and also just the settings where we can reach high-risk HYW, and also using the UNAIDS decision aid. And lastly, in terms of a unique evaluation of a unique identifier code that would avoid double counting. So thank you very much.
Thank you so much, Sandra, for trying to stick to time there. Sorry, we had to rush you, but very interesting presentation. I'm really hoping that we get to see all these slides and then we can digest a lot of these findings. But we are really out of time. So I'm going to quickly go to the next and final section, which is country reflections on how HIV incidence trends and insights can be used at country levels. So I understand Dr. Peter Modiope is available to give us his country's perspective. Dr. Peter is an epidemiologist currently working as team lead for HIV prevention at the Ministry of Health in Uganda. Daily, he provides 360-degree stewardship to HIV prevention teams in Uganda and is a national champion for KP programming. So, Dr. Peter, if you're there, you have about 2 to 3 minutes, please, to give us your country's perspective.
Thank you so much, Dr. James. Thank you, the previous speakers. I'll be fast. And basically, what has been presented here is enriching, and I add my voice to yours and say we shall digest the presentations when shared, but it's a lot of information. Pretty well understanding that most of the issues as presented, like the SHIP project, thank you, Sandra, we are using the vulnerabilities, framework as well for the AGY to prioritize based on the incidence. And this was really very critical during the Global Fund application. But allow me to share something that is very unique to Uganda, which we are calling the integrated community service delivery model. Sorry, I don't have a presentation, but I want to talk through it very fast. This model is based on high incidence areas for HIV. And as you know, what is very unique about the model, in Uganda, we have done data analysis and we know that we have around 80,000 people who have not suppressed HIV. And coming from the previous speakers saying that U is equal to U, and looking at the moderate to high risk population, large populations with moderate risk, which these presentations or webinar was focusing on mainly as a key factor that we should focus on going forward. We have identified these people and the 80,000 people who are unsuppressed and transmitting HIV. And what we have done, we have marked their locations. We have identified peers or community health workers in their locations and attached them to these non-suppressing clients to support them, first of all, to do intensive adherence, to do birthday support for directly observed therapy to swallow their drugs, but also to address the other causes of non-adherence. We have also put in that model another intervention is linking them to socioeconomic services, but most importantly, which I want this meeting to go away with, is that when we get these non-suppressing clients, we do contact tracing, and we do SNS testing, and we also do index client testing. We test their family members, we test their partners and their friends. And we have found out that there is a high yield of HIV positive clients whom we had not reached with other means. And the other services we have under there is TB screening and other vulnerability issues. We have also, it also integrates and screens for other diseases and health problems like mental health and other physical ill health. Mr. Chair, I have a lot to share, but I want to limit it to that an experience of Uganda based on the integrated community service delivery model, which I think if adopted across, we will be able to reach the last person who is not identified or not suppressing. For you is equal to you. Thank you, and over to you.
Peter, thank you so much for that. I know you try to stick to time, but we'll go straight to the last country champion. That's the Ghana country champion, Rita Afriri. Ms. Rita Afriri is a technical coordinator at the Greater Accra Technical Support Unit, Ghana AIDS Commission. Rita has over 10 years of experience working on management and health development issues, particularly in government, civil society, and private sector. Ms. Rita, you have 2 minutes.
Thank you, Mr. Chair.
2 minutes. Thank you so much.
Thank you, Mr. Chair, for this opportunity. I'd like to also congratulate the speakers for such insightful presentation. I must emphasize that the journey that we have embarked upon today has actually been enlightening and thought-provoking. Ghana as a country also faces significant public health challenges, and also the importance of leveraging on HIV incident data cannot be overstated. The HIV incident trend serves as a guide or a compass to our national HIV response. And it helps us to direct towards effective strategies and also interventions that can help us or make a difference in the lives of those affected by these viruses. And through our discussion, I have uncovered a multitude of ways that countries, especially Ghana, can leverage on the incident data at our country level, from evidence-based decision-making and also targeted programming to strengthening health system and also promoting community engagement. I think we have a vast positive change that are abundant that we can take advantage of. Currently, as a country, at the national level, we have national targets for monitoring reduction of new infection, but with the HIV incident data, we are shifting to a system where at the regional and district level, will be available to develop targets to reduce new infection, and also try as much as possible to monitor this progress at the regional and district level. The incident data has also helped us to identify unique needs and opportunities or challenges that can help us to develop intervention and programming for key and vulnerable population. I must also state that currently we are working to develop a roadmap for persons who use drugs so that we will be able to develop a unique and appropriate culturally sensitive programming for persons who use drugs. I would like to close this chapter by saying that we need to prioritize our data collection, analysis, and monitor progress to help our national response. And it means that we need to explore the potential of HIV incident data to drive meaningful change. I would like to end here and say thank you so much for this opportunity.
Thank you so much, Rita. We truly appreciate that. We can take maybe for 30 seconds, we have Dr. Elizabeth Koko from Botswana. Quick remarks from you, Dr. Elizabeth.
Thank you very much, moderator. My name is Ms. Elizabeth Koko from Botswana. As a reflection for the HIV incidence trends that we have heard from various speakers, of course, there are some elements of the promising trends as we have seen it. Maybe as I can provide a bit of background about Botswana is that, as you're all aware, we conducted the 5th Botswana AIDS Impact Survey. And in that survey, we have managed to, it confirmed that we have actually reached the 95 UNAIDS targets. And although we have reached those targets, we know that in Botswana, treatment cascade is actually excelling, but the HIV prevention is still lagging behind. Those are some of the challenges that we are faced with. And then despite the fact that I mentioned about positive strides that we have seen, also is that we have also missed as a country the 2020 fast track targets. As you are all aware that all countries were supposed to actually have a reduction of 75% of new infections, contribute towards that 75% reduction of new infections. And we missed that. We are up to 46% since 2010. Though we have realized in terms of reflections regarding the HIV incidence trends is that the country, we feel that the epidemiological data is quite useful in terms of policy making and also informing the programming. We have actually developed an HIV prevention roadmap, that is actually aligned to the Global HIV Prevention Coalition 2025 roadmap. The intention is that we accelerate HIV prevention in the country to address the bottlenecks and gaps identified by the global HIV incidence data that we have seen. And in that roadmap, our intention is actually look at various pockets of or segments of the population whereby really the issue like HGYW, adolescent girls and young women, whereby we are seeing there is a problem, and also key population in this country. When you look at the female sex workers, the HIV incidence is quite, prevalence is quite high. For HGYW, the HIV incidence also is high. The HGYW in this country constitute 9% of the population, but 25% of HIV infections actually comes from that target audience. So with the roadmap, our intention is that we move towards precision prevention to address the gaps that we have identified. The 5% that is remaining of those who are aware of their status, and also the 2% remaining for the treatment, and then the 2% remaining for the viral suppression. As you are all aware that we are at 95, 98, 98.
Thank you
So we
much.
are really focusing on those. And another area that we would like to strengthen is addressing removing human rights barriers and other legal barriers that impedes access to HIV prevention, treatment, care, and support, and strengthen the primary prevention to prevent new infections among the adolescent girls and young women.
Dr. Coco, thank you so much. Thank you so much. I wish we had more time, so much information, but just to quickly thank you all, especially to the speakers. Thank you all for making our time to be part of this webinar and for answering the questions posed. We will be posting these questions along with slides and recordings of this webinar so that we can better review this rich information and see how we refocus our country programs, our country prevention programs, and maintain prevention intervention for sustaining epidemic control. So thank you all once again. Sorry we took a few minutes extra of your time. Thank you and have a good evening.